Hello and welcome to this edition of Ask Your Doctor. I'm Dr. Alan Thornhill. I've been working in the field of IVF for over 25 years in a variety of different roles, starting as a clinical embryologist in the lab and now providing support and guidance for patients as a fertility coach. This evening, I'll be your host for what's going to be an interesting and important session covering a very interesting question to do with personalized ovarian stimulation. What are the protocols and medications? It's a classic IVF embryology statement to say that the lab can't perform true miracles. They can only work with the biological material they receive. In this specific case, and relating to tonight's topic, that's the eggs. Obviously, the number and quality of eggs is part of every woman's unique biology, but we know that the stimulation can certainly influence the number of eggs obtained, and if not the quality exactly, the maturity at least. I don't claim to have specific expertise relating to ovarian stimulation, but it's a very common question I'm asked by my coaching clients. But luckily, I'm joined tonight by a fantastic set of panelists who are here to help you better understand personalized ovarian stimulation protocols and medications. They are Dr. Panagiotis Drakopoulos, founder of Drakopoulos IVF Clinic. He's an obstetrician-gynaecologist in Greece. Dr. Iñaki González-Foruria, medical director of NatuVitro Reproductive Center in Spain, and Dr. Lyubov Myhailyshyn, head of IVF department at Alternatyva, if I've said that right, Ukraine. I'm going to start by asking each of our panelists to introduce themselves and their clinic with an emphasis on what they offer in terms of personalized treatment, with a focus on ovarian stimulation and what they mean by personalized treatment. Because I think there's, when I speak to patients, it kind of means different things. Given the huge variation in drug names within and across countries, I'm going to ask the doctors please to use the generic name as well as the specific name when describing a drug or medication. For example, if you're talking about an FSH drug, say FSH used to stimulate the ovaries. Then we're going to get right onto your questions, and I've got some extra questions if it runs a bit short. I suspect today will be challenging as it's likely to be very case and patient specific. So wherever possible, I'm going to ask the panelists also to try and make the answers generalizable. Please can I ask you to put your questions in the Q&A box, not the chat, because that helps me to deal with all of them. We'll try to answer all of them, but I will prioritize the ones that are easy to generalize, haven't already been answered, and stick on tonight's topic, just in the interest of time. So without further ado, I'm going to ask Dr. Drakopoulos to introduce himself and talk a bit about the, in general, your personalized approach at your clinic.
Thank you very much, Alan, for the nice introduction. So I'm Professor Drakopoulos. I'm located in Athens, Greece. It's not Drakopoulos IVF Clinic. I have a team, and I work as a collaborator, and I collaborate with one of the biggest labs in Greece called Institute of Life. It's ESO in Athens. So for me, personalized medicine, I mean, it's a term that we use very often, sometimes without understanding what does it mean. So when we talk about infertility, I think it's very important to be close to the patient. I mean, this is what we lack. And by moving in Greece, because I was for several years abroad, Switzerland, Belgium, I used to work in public hospital, university hospitals. And when I came back to Greece, I understood that private, really turn things over, meaning that working in private, we can really be close to patients, understand their problem, and hear them. I think the issue today is that we don't spend time with the patient. The issue today is that we don't spend time with the patients for a consultation. We used to put patients on the same protocol without thinking about their background, their age, their ovarian markers, what they need, what is their family plan. There are patients that, for instance, would like through ovarian stimulation go for a family and not just have one baby. So I think there is different things that we can evaluate, and we will have the time today to discuss all these aspects in detail. So thank you, Alan, and the floor is yours.
Thank you. That's great. So I'll ask Dr. Iñaki the same thing. Introduce yourself, your clinic, and what it means to you, personalized treatment for patients, please.
Okay. Thank you, Alan, again. Well, as you said, I'm also a gynecologist. I'm based in Barcelona. I'm currently the medical director at NatuVitro, which is a small clinic that started functioning just 3 years ago. And I completely agree with Professor Drakopoulos in the sense that for many years we haven't had the time to listen to our patients. Obviously, nowadays, we could say that personalization in medicine is not the future, but it's the present, as we are all different. So we can see it easily with cancer patients, for example. So cancer patients, the treatment for cancer depends largely on each case. And it is something that's going to be the same in assisted reproduction, and probably in every single step of assisted reproduction. It's not going to be the same to stimulate two patients, or the luteal phase for those two patients might not be the same as well. So we have to know what are the aims of the patients, what are the preferences, and obviously try to adapt using the best standards medicine that we can in this moment. Obviously, always trying to use evidence-based medicine. That's what we're going to talk about this evening, I guess. So thank you again.
Okay, great. Thanks very much. And same thing for Dr. Lyubov, if you wouldn't mind. Thank you.
Hello. It's first of all a great pleasure for me to be with you today, and it's a really big honor to discuss this important unit in IVF. So I'm currently the head of, I'm Lyubov Myhailyshyn. I have 22 years experience in IVF unit, and currently I'm head of IVF department in clinic Alternatyva. It is located in the West Ukraine, so we're a little bit more safer than the rest part of Ukraine, unfortunately. Regarding, I worked for 8 years as representative of Ukraine in ASHRAE in a committee of national representatives. And regarding the question of individualization of stimulation, for sure we realize that there is a huge individual variability among our patients, and we have included everything. I think that we have to discuss with them what do they eat, about their lifestyle, what comorbidities they have. Even we know that some types of vitamins, even folic acid or some microelements, can have some negative impact. I mean that overdosing of some of them, even we have some studies showing that. So we have to account everything, I think, when we want to individualize the treatment, because the same drug even can act in different ways, even depending on the place where we make the shot. Like in abdominal obesity, we can have a level slower action of some kind of medication if we would make this shot to the shoulder, for example, right? So everything does matter. So we are trying to do, all of us are trying to do our work in the best way, I am sure.
That's great. Thank you. I'm already hearing in the answers a nice broad, not just saying, oh, personalized medicine, that's what we need to do, because it's easy to say it and it's a lot more difficult to actually deliver it, right? To avoid us just doing the same, doctors in the same order, I'm going to switch it up each time. So actually, I'm going to stick with you, Dr. Lyubov, and we're going to ask you the first question from the patients. And for the other doctors, obviously listen to the answer and think about if you've got anything different to add. If it's the same, we're just going to take it as read that you do the same thing. But if you have a completely different view, then please, raise your hand or something, and we'll cover that. So I'm going to drop straight down to the bottom because I saw an interesting one just come in, and this comes up quite a lot with patients I speak to. Duostim. So let me put it on the screen quickly. Do you think Duostim is suitable for a 40-year-old woman? Okay, and in your answer, please generalize it to say, if you don't think it is, say, no, this is the group that I think that it's good for.
Well, I do think that this is nice idea, just because that we short this time frame, this period of time when we harvest these oocytes. So it gives us a possibility to get the oocytes quicker in a shorter period of time. Well, it's still very controversial whether we get more euploids embryo in the second stimulation. So at least we don't have evidence-based confirmation, because we suppose that maybe this previous stimulation improves the answer, the second answer, or even when we make the egg retrieval, the egg, this needle helps us to activate the ovary, because we talk too much now about PRP, and the egg retrieval is like kind of PRP because thrombocytes are already there after the egg retrieval. And we know even about quadrastim from Robert Kasper. So we still do it because in a phase of advanced age, we don't have enough time. So I think that it's a nice idea in this group of patients, only just to make this time shorter. And anyway, we mostly use PGTA in these couples, so anyway, we freeze. So I think this is a nice idea.
Okay, and for the other doctors, do you have anything, dramatically different to say about it, or should we move on to the next question? Okay, we'll move on. We'll move on for now. So I'm not sure I understand that quite. Okay, so now we have a patient, Dr. Iñaki, I'll ask you. Patient who's 39 with stage 4 endometriosis. In their last cycle, only got, let me put it up actually, only one egg of 12 were mature. What can they do to improve maturity of eggs? And in your answer, think about endometriosis, but also think about any situation where somebody has very few mature eggs and what maybe can be done differently.
It's a very nice question, and it's something that we see in our daily practice. First of all, we should know in this case which was the protocol they used for the stimulation. It's not the same using a long agonist protocol, which was quite used in the past for endometriosis, or whether they used an antagonist protocol or a PPOS protocol. And it would be interesting to know as well which was the triggering that was performed for this cycle. So it's probably related to the trigger, and probably it's something that we could improve. And also, it would be nice to see which were the compounds used, so the gonadotropins that were used in order to stimulate the ovaries. So it's true that most of the times that we have a bad number of mature eggs, we can correct it a little bit. So it could be a problem of the cycle, but there are patients that we don't really know why. It's not a matter of the cycle. We do completely different things in the same patient, and the results are the same. So from my perspective nowadays, I believe that when we do IVF, most of the times we freeze. We systematically use almost always dual trigger, so HCG and agonist trigger at the same time. And here the only concern is whether this patient should have been using LH activity during the stimulation.
Okay. Thank you very much for that. That's very interesting. And you're right. You know, if we don't have all of that information, it's hard to give a very specific answer. I'm just going to tag on a little question at the end of it, though, is when you see a situation, maybe a patient's come from another clinic, and this is not about bashing the other clinic and saying they've not done a good job, but do you think that it's perhaps a protocol has just been followed like it's standardized, it hasn't been very personalized, and that's why they've not got the good result? Or in your experience, is it because this person has sort of intractable ovaries? You know, it's quite difficult to get mature eggs or a large number of eggs from them. You know, what's your experience been with that? Or just very difficult to answer? Normally
when people come for a second opinion, the first thing we have to do is to be humble, because when you see the patient for the second time, it's easy to tell things were done not correctly, and people will believe you because you are in a privileged position. So we have to be humble. But at the same time, we have to tell the patients, look, as I said before, there are things that will remain independently of what we do with you. There are things that we can change, and maybe it's because the cycle is different, things will be different. So it's not specifically related to the change that we can apply, that the results will be different. So obviously, for the sake of the peace of mind, we will change things because we want to have solutions and trying to be intelligent to find out which are the good solutions. But it might not work. So this is something that we should tell the patients from the most transparent way.
Thank you. That's a really nice balanced answer. I really appreciate that, because, you know, again, I speak to a lot of patients who say, I went to this place, oh, look what happened. And they expect the next doctor to wave a magic wand and say what happened before was terrible, which, you know, sometimes maybe it was, but not all the time. So thank you for that. So I'm going to go on to Professor Drakopoulos now. And this question, I'm going to summarize it, but I'll put it up on the screen anyway. It says, what do you think about the studies and the use of oral contraceptives for scheduling purposes for IVF? So some studies showing that pills decrease the number of collected eggs, implantation rates, and other outcomes. And I suppose this question is, you know, really about, because it happens in embryology too, or it did in the past, you know, are the clinics doing things that make it work more efficiently for them, or are they doing things in the best interest of the patient? So I'll pass that over to you. Thank you. We can't hear you at the moment. I think you're on mute.
Yeah, thank you for the question. It's indeed a very relevant question. So indeed, contraceptives is a relatively controversial topic. There have been some studies showing that pregnancy rates after the use of contraceptives are lower. However, there were recent studies showing that this is not true. However, I think that when we use contraceptives for scheduling, it's a perfect idea. And then we proceed with freeze-all. Personally, I use contraceptives in order to schedule the cycle. Maybe it's not only for us, it's also for the patient. Maybe the patient wants to go on holidays, whatever. So we can use contraceptives in order to schedule the cycle and then freeze all the embryos. So personally, I don't perform fresh embryo transfers before following the use of contraceptives because of this doubt regarding the effect on the endometrium. But for scheduling purposes, I think it's a perfect tool, and I really use it very often in clinical practice.
Okay, so that's your practice. So can I summarize that and say, for fresh cycles, because of the uncertainty of the potential outcome, you wouldn't use it in a fresh cycle?
Yes, I wouldn't use it in a fresh cycle. But given that nowadays, 80 or 90% of cycles are freeze-all cycles, I think that there is a place for contraceptives in clinical use.
Okay, thank you very much. Dr. Iñaki, I told you I'm switching it around, so you never know when you're going to be called. Can women, and I guess when it says their spouses, I think that means they're experiencing it, adjacent, expect hormonal changes in temperament and mood swings during ovarian stimulation? This particular questioner says, my personal experience is yes, but can you say a bit more about that and what can be done to, mitigate that?
Well, that's one of the questions that probably most patients ask us before starting stimulation. What would happen to me? Will I get mad, or will I kill my husband? What's going to happen? From my experience, and I don't know your experience, probably you'll feel the same. It's quite unexpected. Probably most patients they believe the effects are going to be much worse than what they really experience during the stimulation. And it has to be said that the stimulation takes 10 days normally. So it's not that huge change for a long time. What I normally tell them is that they can do their normal life, but they will probably feel more swollen at the end of the stimulation, especially after the trigger, especially if we use HCG. So if we use HCG, they will feel more swollen the day of the pickup and a few days later until the effect of the HCG is gone. But it's true that normally these hormonal changes are very, very transitory. So most people can manage them, most patients can manage them easily.
Okay, thank you. That's really helpful. I think that's particularly useful, saying it's hard to predict what the effect is going to be. And I suppose that old adage, kind of expect the worst and hope for the best, right? There's an element of truth in that, isn't there? Okay.
Exactly.
Great, fantastic. Okay, next question. I'm trying to pick all the ones that are absolutely specific to stimulation at the moment. Dr. Lyubov, what do you consider the best 3 protocols? We'll start with your favorite one, I suppose, for a woman of 40 with an AMH of 1.1. Obviously, we do, it would be helpful to know which particularly, I can't think of the word, which scale we're using for the measurement of AMH to try out. So would you like to answer that one, please?
Thank you for the question. I would use for this lady the protocols with antagonist. I'm still scared about PPOS because a low LH in this. I'm still not sure that it will be enough LH even So I would just use the protocol with antagonist. And frankly speaking, I like letrozole. You know that just recently Nicholas Macklin published a very nice study and meta-analysis. We know that we use, oh, sorry, I forgot it. We have to talk just about medication inhibitor of aromatase. So we know about these medications from decades ago when we used them in fertility preservation for in oncological problems, right? So we used them and we saw that estradiol is low, but we were still afraid what's about the oocyte quality. But Nick Macklin just recently showed that we can even increase the live birth rate for 7% of in this type of patients. So I will still think about for definitely using LH, because we know that it is extremely important in these women. We need to I would avoid definitely birth control pills. Maybe it was very short period of wash-upping, because we know that also they reduce the LH in these couples, in these women. So it will be the protocol with LH, with like 2-to-1 maybe proportion between FSH and LH. And I will think about what's about the use of aromatase inhibitors together. And definitely it will be the double trigger, the HCG with GnRH agonist triggering. So maybe you have something else to ask me about this, or we don't know the diagnosis, we don't know some other, whether she has some additional problems, right? Her weight, her maybe problems, I mean, with endometriosis, etc. We are not discussing it, right? Just women of 40 years old.
Yeah, the question that we received, normally there's tons of information, but this one was actually very brief. And it said, what are your top 3 protocols? But
okay, so duo-steam, yes, they know that. Yeah, maybe I will think about the duo-steam for her. Also, sometimes I practice so-called primering with very low dosage of GnRH agonist. So like for 7 to 8 days before in the luteal phase of previous cycle. So sometimes it helps us like to, for FSH come early a little bit and like to prime it. And then I stop it on the first day of the cycle, and we'll start again with FSH and LH, and then we'll add the antagonist, like with the proper size of the follicles, and continue with double triggering.
Okay, thank you. That's really useful. I'm going to stick. There's some other questions. One that's actually I'll put up on the screen, and the other one I'm just coming out of my head. I'm going to stick with the older patients, let's say over 40 years, and ask Professor Drakopoulos about dosing of gonadotropins at an older age, because again, I meet lots of patients who say, oh, I'm on like the highest dose, and it'd be nice for you to sort of summarize the evidence in terms of, do you need to just keep going up and up and up, or actually are there arguments to say don't go too high on the dose?
Yeah. Thank you for the question. So regarding the highest dose, we know we have evidence that we should not go over 300 units per day. This we know because sometimes we see patients coming to stimulation with 450 or even 600 units per day. Then for older patients above 40, I think that a mild stimulation approach could be used, and studies have shown that by using a mild stimulation compared to conventional stimulation, we get the same number of oocytes. Of course, it depends also on the AMH and the antral follicle count of the patient. Okay, but if we take into consideration that probably we talk about a patient of 41 years old with a low AMH, low antral follicle count, I usually use 150 units of gonadotropins per day, usually with LH activity. And yeah, so I think that for sure we should not exceed the 300 units per day. I think that even with 150, we can definitely do our job in patients with low ovarian reserve markers.
Okay,
with
lovely.
the addition sometimes of letrozole or clomiphene, but yeah.
Okay, great. Thank you very much. I think that's really important, because it's a bit, I know this is going to sound weird, a weird analogy, but I speak to men about taking supplements, to improve their sperm. And it's understandable, but people have got this mindset of, more is always better of everything. And we know it's not true of supplements. And we also know it's not necessarily true of gonadotropins as well, right? So
yeah, indeed. I mean, if we have a patient, for instance, with an antral follicle count of 4 or 5, even by giving 150 units per day, you can get the number of eggs that you can based on her AFC. So I think everything has to do with the age, but also the various markers. So we should not go always to 300 units per day. We can definitely do our job with a lower dose, especially patients with a low atlas follicle count and low AMH.
Well, that's great, because that is absolutely on topic for tonight, which is personalizing it. It may not be super specific to that patient, but it's like you're older, but it doesn't automatically mean you need the highest dose, right? That's really good. So I'm going to move on to Dr. Iñaki now. We're sticking on the theme of older patients. This question says, do you recommend taking DHEA for a woman? And please explain what it is and what it does for a woman of 44 years. But if you can generalize, maybe say, if you believe there's some value, at what age would you start considering using it? You see what I mean? Rather than just saying, oh, it's 44 or it's 43. And you might want to also, sorry, I'm giving you a lot, and the other doctors can answer this one as well. You might also want to answer the question, have you had success with a patient aged 44, whatever you did? Okay, because that one comes up every time we have this panel show.
Well, thank you, Alan. The question is so tricky. It's tricky because, well, for those who might not know, DHEA is a compound that's a precursor of testosterone. And what happens with the ovary, with the age, is that we lose testosterone, which is one important compound of all the folliculogenesis and the development of the follicle. So it has been suggested that giving testosterone or precursors of testosterone could improve the development of the follicle, could improve the levels or the maturity of the follicles, and therefore give better quality of the eggs. So there have been research looking on that. The latest research, at least to my knowledge, is one randomized control trial performed all over Europe that was managed by Nikos Polithos. And it was not performed using DHEA, but it was performed using testosterone, which is the final metabolite. And the results were the same. So DHEA can be used orally, which is easier, but at least using evidence-based, we cannot tell that we're going to improve the outcomes. So it's not a matter of cutting the patient for the age of 40, 44, 39, 38. We can use, because it's true that even though it's off-label, we can use DHEA. It's not going to harm our patients, but we cannot tell them to use them and to make sure, or to tell them that it's going to work for sure. This is not true. Regarding the experience, the second question, Alan, obviously, we've been working for many years. We have seen things that we cannot really understand and that were successful, and we still don't know why. But normally it's quite hard. 44, we know that the live birth rates per cycle are 1-2%. So it's not in general. Obviously, it depends largely on the ovarian reserve. But in general, 44 is 1-2% live birth rate per cycle.
Yeah, and I realize I'm putting you all on the spot asking that question, but I guess we're having a very honest conversation, and I meet a lot of people around that age group, as you do, but I'm only seeing the ones who are saying, this is what I've been told, or this is what I haven't been told. And I say to them, just look the person in the eye and say, have you been successful at this clinic? That is not the same as, is it possible? We know that. Of course it's possible. And you can throw a 1% in there, and that's a low number. It's an honest low number, but it's not the same as, well, it's never worked here. So that's why I ask people, because I just want that kind of level of honesty, so people can go, okay, well, let's think about what we can do, what might work, because most people have limited resources, right? So that's why I asked that question. Okay, and when I ask the other doctor's question, feel free to throw in your own answer for that as well. But I'll move on. I'm trying to summarize several questions. There's quite a lot of people asking specific things about their specific case, and I'm going to ask Dr. Lyubov this one. But I think what they're getting at is, should I use a particular brand of FSH to improve my chances? So if you could talk generally about why that is a good idea, or maybe not such a good idea, because again, I meet lots of patients who say, oh, I was on Pergoveris and I think I should be on this other thing. Aside from LH, but feel free to mention that, why would you switch drugs for, it's a gonadotropin? Lots of randomized studies have shown not really much difference. What's your view on that, please?
Thank you for your very nice question. What do we know now? That in vivo, we have very different types of LH activity. At least 50 is known. So many isoforms we have in vivo. So that is why the question is still complicated. We know about LH because LH is the top difference. It's a key for our question for the stimulation process. So we know that there are different types of LH. We have recombinant one. We have one coming from highly purified HMG and one from chorionic gonadotropin HCG, right? So we know that they bind the HMG and HCG, they bind the same receptor of LH, but they have two different types of action because like recombinant LH, it works for the cell proliferation and for growth to prevent apoptosis, and the HCG is binding the same receptor, but it acts through the steroidogenesis. So like recombinant LH is like more common for what we're looking for. We're looking for the growing of the follicle, right? But frankly speaking, if the patient is young and if everything is okay, so I'm sure that there will be everything okay anyway, even with FSH, right? If we don't use like very down regulate the LH by long use of birth control pills, or we use PPS or something else, or she has hypothalamic like very low coming from her hypothalamus LH. But I would, in older patient, I would still use recombinant LH, especially with poor responder, especially if she's aged. But if she's like, because frankly speaking, I use in my own practice for all patient LH. We still are afraid of different types of genetical polymorphisms that can be everywhere. We don't know if we are stimulating for the first time whether will have this enough fort, whether all follicles will grow together, right? Because sometimes we see enough follicles, we just give FSH, and we see that we don't have enough response. So we realize, well, in the second stimulation, I will start with LH, but this protocol will be missed, right? So frankly speaking, in my practice, that is why I'm trying to avoid all of these cases. And I start from the very beginning with LH. But yes, there is still a difference, but also in my practice, if I see that we had some like not very nice answer with this type of LH, I will make some way different in the next protocol. Whether we can overdose LH, it looks like that no, but I fully agree with Professor Drakopoulos that yes, sometimes we have to be afraid of this harmful effect on oocyte quality if we overdosing total gonadotropins. Sometimes we can have better result with the lower dosage.
Okay, thank you. I'm going to just ask a tag-on question to that, and if you can give a sort of brief answer and include the thing about at your center, not your experience, something you saw 20 years ago. At your center, this lady comes into your clinic. She's 45. She has low AMH, not specified. She wants to try one last time. What are you going to say, and what protocol are you going to use, or are you going to say don't bother?
So what AMH does she has?
It doesn't say. It just says low.
Oh, well, yes, it's really complicated. Well, but she have to try at least, because nobody knows. Like so. Anyway, wow, what I would recommend her? I would prescribe her recombinant LH and recombinant FSH for the stimulation. Whether about DHA, well, she can do it, but just in case, I will check her hormone levels. What is about growth hormone using again? Because we also knew a lot about this from the first study of 2007 from Iñaki. Yes, sometimes in such a complicated cases, I check not growth hormone, but insulin-like growth factor to check whether it is okay. And I sometimes give a small amounts of it if this person doesn't have any tumors, like a lot of fibroids or like some nodules in the thyroid gland, etc., because it can produce proliferative diseases. But I will discuss with her such an option, even double triggering, and let's try. Maybe she's PCOS patient and she will be lucky to have enough eggs and maybe even a euploid embryo. But anyway, we realize that it's very low chance. If she will have like 0.1 AMH, I will really recommend her egg donation.
Okay, thank you. That's where I was. I know we haven't got that data in front of us, but that's where I was going, because I mean, in talking to people who have limited resources, money and psychological and health and everything else and time, a very tiny chance probably isn't necessarily the kind of chance they're looking for. But thank you, Professor Drakopoulos. And feel free to bring in as much data as you've read about or done studies on. How many cycles are too much? I'd quite like to know, what are the risks of a stimulated cycle? If there's differences in different ages, that's useful to know. This patient or this person is asking specifically about brain cancer, other cancers. So please, if you could summarize that would be lovely.
I mean, it's a common question. I mean, that we receive in our everyday consultation. Based on studies and on meta-analysis done on the topic, we don't see an association between IVF treatment and the risk of cancer. Of course, after the age of 40, personally, I recommend at least a breast ultrasound or mammography to my patients. But there is not an upper limit of cycles after which we increase the risk of cancer. So personally, I don't have a cutoff in mind regarding the number of IVF treatments. So yeah.
Okay. No, that's really reasonable. Thank you. Do you, aside from health risks though, how many times would you allows the wrong word, but recommend a patient to go through IVF if they're unsuccessful, not when they're building a family, just unsuccessful?
Yeah. I would say, I mean, based on my personal experience, and of course, because we need to be transparent with the patient. For instance, I heard before my colleague talking about a patient of 45 who cannot encourage this patient to have 4 or 5 cycles of IVF at the age of 45. I would say that in general, for me, 5 or 6 is the upper limit for IVF, of course. Then it depends on the outcomes. So it depends every time on the response. It depends on what we get. It depends on many things. Okay, so it's completely different to have a patient of 43 years old that has already undergone 4 ovarian stimulation cycles and comes to us. Then in that case, I would go just for 1 more, and then I would recommend egg donation, compared to a patient of 36 that comes to us after 3 cycles. Where no PGTA was done, where we didn't have good quality. So everything has to do with the history of the patient, the age, the protocol that was used, the comorbidities, of course, and the outcome of each cycle.
Perfect. That really, I'm loving these answers because they're very personalized. They're listening to the patient's needs, looking at the patient in a holistic sort of 360 way. Each doctor now, every question, well, I'll do it in turn. If you could just answer this one, Professor Drakopoulos, just because this is useful information for patients who are listening, because this is kind of like your showcase. Is there in Greece, it's probably been answered before, but I can't remember off the top of my head. Is there an age limit for using your own eggs? And is there an age limit for using donor eggs? Just give us a number if you've got it.
The age limit is the same for both own eggs and egg donation. That is 54. Okay. So even if you have a patient of 49, theoretically speaking, you can suggest IVF if she wants to. But yeah, the age limit is 54 for egg donation and IVF, of course. 54, it's impossible to do an IVF, but yeah. I mean, legally speaking, there is it's the same cutoff. Yeah.
Perfect. Thank you very much. That's really helpful. Dr. Iñaki, okay, we're back to you, and got a question here from a lady. She's 45, and as you will see, a lot of these questions are from people 43 and above, and so they're looking for these very specific ways to increase their chances, improve their egg quality, improve their egg numbers. And this one's about ovarian PRP, and we've had similar questions a lot of times. Can you talk about summarize the evidence for ovarian PRP to help with egg quality? And of course, if you can answer that question about in Spain, the ages for egg donation and own eggs, please.
So I will start with the second question. Also, as we know, the numbers in Greece. In Spain, the law is not that clear because it says the natural age of the menopause. So this is something controversial. But the Spanish Society of Fertility settled 50 as the age limit for egg donation and IVF as well, so for treatments. Then it depends largely on each clinic where you want to put your cutoff, at which point you stop stimulation, or if you want to do an internal committee to analyze each of the cases. That depends on the clinic.
Okay, thank you.
Regarding the PRP, for all the audience who might not know, PRP is the plasma or the platelets-rich plasma, which comes from a blood sampling, which is purified, and then we use the PRP in different types of medicine. It was really useful in traumatology, in orthopedics, and also in cosmetics and dermatology. And now we're starting using it in assisted reproduction in the ovaries in order to improve the response of the ovary and in order to improve as well the quality of the eggs. That's the idea. And also some other centers use it also in the endometrium in order to improve the thickness of the endometrium or the receptivity. It's true that the evidence is quite scarce at this point. And from my perspective, from my experience, the PRPs that might work are those that are performed in younger patients who are 30, 32, 35 with premature ovarian failure. It's still to be delucidated whether the results, the improvement might come from the PRP itself or only for the fact of the trauma that we create on the ovary and the activation of the hyposignaling that will induce the activation of primordial follicles within 2 or 3 months later. But not for a 45-year-old patient, unfortunately.
Okay, thank you. That's really helpful, really balanced. Dr. Lyubov, back to you. I just need to ask you a quick screening question first. The screening question is, do you perform PGTA in your clinic?
Oh, yeah, sure, yes. We do perform it, yeah.
That means I can ask you this question. Otherwise, it's not really fair to ask you the question. So this one, it's very specific to this patient, but I want you to generalize because I remember some data coming out a few years ago and I don't think it's been followed up. So this patient's 41, diminished ovarian reserve, had duostim with PRP at first retrieval, standard antagonist, 13 eggs, 10 blastocysts, which is pretty good, all aneuploids from PGTA, assumed poor egg. That's often what people say in the lab when things don't work out, poor eggs. But so the general question is, can a change in stimulation protocol at any age, but let's focus on this slightly older age, impact the PGTA outcome?
Yes, thank you for this very nice question. And yes, what do we know from the studies that the euploidy rate differed significantly from laboratory, from clinic to clinic. So from this study, we realized that a lot depends from the stimulation, from the maybe preparation of patient, but kind of stimulation, and also what happens in laboratory. So generally, what's about PGT as method? We do know that we can have some kind of mistakes, of so-called mistakes, because we just are taking 5, 6, up to 10 cells from trophic to derm, and we are not sure whether the whole embryo is the same, whether the inner cellular mass is the same. So what do we know from 2 studies, very famous studies, one from Daniel Sakas and another one from Santiago Monet? They showed that in younger patients, the cumulative live birth rate was lower with PGTA because maybe of these so-called mistakes. But in aged patient, for sure, we will definitely also recommend to make PGTA at the age of 41 years old. So what I will think about, maybe the dosage was overdosing. So sometimes we have some studies coming, not about PGT so many, but about some metabolic changes in the, even changes in telomeres. There are studies showing that this ovarian stimulation can have a negative impact on the embryo quality. So yes, we have to discuss it. We need to remember about importance of LH again in this stimulation. Maybe it was just only FSH in the stimulation, we don't know. So we have to look very attentively, and maybe we'll think about maybe something wrong was happening in laboratory, because 10 embryos is too much that we don't have anyone healthy. Maybe we have to discuss about the husband. Maybe he has very high DNA fragmentation rate. So we have to think about that.
Okay. I mean, this is my field, so I could get into this a lot. I think the evidence is not strong that stimulation is directly related to, let's say, the most important aneuploidies. I don't think the evidence is strong. I think it's quite weak, but plausible. I think what the evidence is strong is, as you said, the laboratories can create different levels of so-called aneuploidy, possibly mosaics, and questionable results. And that's what we need to all improve on, right? That's a really important thing. So I suppose the answer to this patient in terms of should they have a different stimulation? I mean, I think what I would take from your answer is perhaps the key is not to get absolutely as many embryos as possible, is to get an optimal number of embryos. Would you agree with that?
Yes, definitely would agree.
Okay.
Yes, because euploidy rate, I agree, because we have these studies confirming that even low dose and high dose have the same euploidy rate, right?
Great. So I suppose that's a nice segue to ask Professor Drakopoulos. Do you have an optimal stimulation, in terms of the outcome you're looking for, the number of eggs? I realize that may change according to the patient and their particular medical diagnosis, but is more always better? Is the question really?
Yeah, that's a very good question, Alan. I need to say here that fortunately, thanks to PGTA, we can have meaningful outcomes for the patients. What I mean by that is that based on age, we know what is the optimal number of oocytes in order to get one euploid embryo, so one genetically normal embryo. So this is an outcome that I always use in my consultation, and it's something that now patients understand. Okay, so personally, I offer and I recommend strongly PGTA to all my patients after the age of 38. Why? Because you can have answers, and this is important for the patient. Also, we can explain to the patient the number of oocytes that we need. So maybe we can get this number of oocytes with one cycle, or maybe with 2 cycles, or maybe with 3 cycles. But always I try to reach this optimal number of oocytes based on age. Of course, it depends also on the various markers, in order to have a good probability to have one euploid embryo. And based on my experience, it's something that patients like. And also it's easier for them, if it doesn't work, to move to another option, like egg donation. On the contrary, if you have a patient, for instance, of 43, 42, 43 that comes to your clinic and she doesn't want to have PGTA and just wants to have a transfer, and in fact, if we don't recommend PGTA and we just do a transfer, probably the transfer will fail. But on the contrary, if we perform PGTA and if we have unemployed embryos, so genetically abnormal embryos, then it's much more easier for the patient to understand where is the problem and to move to the next step. So yeah, this is my personal opinion.
And that's been my experience too, that somebody who says, look, I've got the body of a 35-year-old when they're 45, and then you show them the results and they're all abnormal, it kind of does, it does move things in a different direction. There's quite a few questions linked to supplements and what can I do without a medical intervention to improve my egg quality. So I'm going to ask that one to Dr. Iñaki. It's a difficult one because there's a lot to cover, but if you could sort of summarize what you say in your clinic in terms of supplements, including CQ10, vitamins, sort of over-the-counter type stuff. And the 3 things I'd like you to answer is, what, what has evidence that it works and is worth them taking, dose, and what might be the outcome of having an overdose, and when to start and when to stop, please. I know it's a lot, but that would be very helpful.
Thank you, Alan. It's a common question as well. So many patients ask for that, maybe because they have asked someone else before, or they have a nutritionist that recommended something, or either because they were already taking supplements by themselves. It's nice because we have recently launched a guideline on supplements in the Spanish Fertility Society, and we try to summarize each of the supplements very easily in a traffic light. So the green light, let's say the orange light and the red light, and almost most of them were orange. Orange means that there's not enough evidence to suggest the intake of those supplements to improve the outcomes. I'm talking about vitamin D, I'm talking about melatonin, coenzyme Q10, omega-3, many supplements, which doesn't mean that they might be dangerous. And this is something that we should tell our patients. So you can take them, but also do not rely on that to have real changes on the outcome of the cycle. Obviously, if we have one failed attempt with something that didn't work out and we expected better results, probably we would wait for a second cycle. And when we do the second cycle, we have to change things. Maybe because it works, maybe because the patient needs to change something, not to do the same over and over again and expect different results. That's insane. So in this case, what we recommend when patients ask us for supplements, we tell them, look, you can use coenzyme Q10, for example, 200 milligrams per day. You can use vitamin D according also to your vitamin D levels. If you have deficiency, you can use either a shock supplement, or you can use daily vitamin D intake if you want to. You can use omega-3, 1,000 milligrams per day, for example, melatonin. So either you can use hundreds of individual pills, or you can use all these combined pills that are using all the supplements all together. But it's unfortunately, according to the literature, the evidence is quite scarce, so we cannot recommend as a real solution for these problems.
And that's really helpful. Thank you. And it's very interesting for the audience, your colleagues and me, to know that you've come up with a traffic light system for supplements in Spain. That's fantastic. Those are really sort of helpful things. But I do have a sort of follow-on question, and it comes from a sort of scientifically, I feel quite secure about this, but experientially, I don't. But I went to an interesting talk about oxidative stress, and it gets talked about a lot, doesn't it? And, I mean, even the audience who may not be scientists know that, antioxidants are the superfood of today, right? So everyone's trying to reduce inflammation, reduce oxidative stress. But in basic chemistry, if you do too much of that, you get reductive stress, right? Something the opposite happens. So that sort of leads to my original question about can supplements be harmful? And maybe some aren't, but I think the rule of thumb probably is don't exceed the dose. I remember from my pharmacology in college, they said everything is poison. It's just the dose that matters, right? Do you agree with that?
Well, I agree, but we don't have answers.
Okay.
So we cannot tell whether if you take 1,000 milligrams per day of coenzyme Q10, it's too much, and if you take 200 milligrams, it's beneficial. But as most things in medicine and in pharmacology, yes, you have your therapeutic window. If you exceed the window, probably it's harmful. If you go below the window, it's probably useless. But we don't know, according to the supplements, which is the dose. For example, we have more information about the doses on gonadotropins. So we know the window in gonadotropins, probably as Professor Drakopoulos said before. If we exceed 300 units, probably it's useless, and it might be even harmful in terms of ovarian response. But it's not the same for supplements. We cannot tell the same.
Okay, thank you. I'm going to generalize. This is a good question. I'm going to generalize it a little bit for Professor Drakopoulos. So this is very specifically, it says, during stimulation, can the dose of FSH be increased if follicles grow too slow or reduced if they grow too fast? And I guess the general question is, how much evidence is there for this sort of tweaking of the protocol once you're in it versus deciding the protocol up front based on all the parameters, based on all the data that you have up front, including past cycles, and tweaking it along the way. Can you say more about that, please?
Yeah, I think there has been a survey regarding dose adjustment during IVF, and it seems that 4 out of 5 doctors perform dose adjustment during IVF. Personally, I'm against dose adjustments. I think that we should choose the right dose from the beginning. And if we think that LH supplementation is required, we should start it from the beginning. However, it happens sometimes when we use the antagonist protocol on day 5 or day 6 of stimulation to see the patient and there find out a suboptimal response. And there we have 2 options. Either we increase the dose or we add LH activity at this point. Personally, I never decrease the dose because in an antagonist protocol, we are in a safe mode. We can always trigger with an agonist and practically eliminate the risk of ovarian hyperstimulation, because some patients still think that they may suffer from hyperstimulation, from ovarian hyperstimulation syndrome. So yeah, I think it's something. Just to return to the question, I think dose adjustment is it's something that is done by many doctors. Personally, I don't think that there is a role of dose adjustment, except of specific cases, and we should choose the right protocol and the right dose from the beginning of the stimulation, and not just play with the doses during stimulation.
Okay, great. Love that. Yeah. I mean, again, I'm not a doctor. I've not had to do it, but I've witnessed doctors tweaking things all the time. And as a scientist, I've thought, what's your evidence for doing that? and will we learn anything for the future? Because there doesn't seem to be much record of it, but that's just that's my personal opinion. Okay. I mean, and in a laboratory setting, I don't just mean IVF, I mean general laboratory setting, you don't learn anything unless you stick to the protocol and say, right, I did it that way. This is the answer I got, and now I'll try something different because I know what answer I get when I do X. Thank you. That's really helpful. Dr. Lyubov, I'm going to generalize this question. It's very specific. It says, are there any reasons to freeze embryos on day 3? Let's not get into the embryology part. I'm going to sort of ask it more a stimulation way. They've put, is it a sign that they're not updating their protocols and their approach is old-fashioned if they're doing things on day 3? My question really, to make it more general, is are there stimulation differences that would lead you to get better day 5 embryos or day 3 embryos? Do you see what I mean? Is there a difference, or really, if you do the stimulation right, you should have good day 3 embryos and good day 5 embryos?
Yes, thank you again. I really truly believed that we have to stop freezing on the 3rd day. So as far as we know from all this knowledge and from laboratory, I personally think that we do not harm freezing the 5 days. So it looks like that we do not lose the embryos when we keep them moving in the laboratory from the 3rd to the 5th day. There is one very nice study. It was published by, again, Santiago Monet, and it was in Human Reproduction, probably in 2018. So it was very ethically probably problematical study. But what they did, they just inseminated women, and they washed out the embryo outside of the uterus, and then these subfertile women were underwent through the IVF and stimulation, and they compared these embryos which were obtained in the laboratory and which were growing in the uterus. And what did they show? That there was no significant statistically significant difference between the euploidy rate in the blastocysts obtained from the uterus and from the laboratory. There was just a little difference in the mosaic level. So it was a little higher mosaicism in those embryos which were growing in the laboratory. So it means that our cultural medias, our incubators and etc., it looks that they do not harm for the embryo. So we do not expect that this embryo will be better quality on the 3rd day So like we are like losing embryos in our laboratories if we then keep taking to the 5th day. So in my daily practice, we don't use it anymore.
Okay, thank you. I see we're getting close to time, and I don't want to, I'm very grateful for your time, doctors. So there are a few more questions, but I think some of them have been answered in tangential ways. I've got a question here, and I'm going to ask all the doctors this one, because I think this is important, because everything we're talking about is very specific to specific patients, and that's kind of the whole point of personalized, as we discussed at the beginning. But I want to ask the question, given that everybody talks about artificial intelligence and big data sets, and this isn't a new idea, actually people were talking about this 10, 15 years ago. So here's my question to each of the doctors, and then we'll close it off. Will AI, artificial intelligence, and big data sets from past cycles help doctors in the near future, or is it already happening in your practice, or even replace them when it comes to stimulation decisions? So I'm going to ask Dr. Iñaki that one first. Do you use any tools, algorithms, AI, or is it in your head?
Thank you, Alan. Not really at the moment. We are not using algorithms or artificial intelligence for ovarian stimulation. But I think I would like to address this question not just in ovarian stimulation, but also in general in medicine. So I think that our work has two different parts which are attached one to the other. One is the knowledge, the know-how. So how we deal with a certain problem in medicine. And this probably artificial intelligence will easily be superior to the human. So it's something that we have to understand. But probably it's also our fault that the second part that is attached to this one is the human touch. The human touch is something that many doctors we are losing because we don't have time to be with our patients. We don't have time to listen to them. We don't have time to talk to them, trying to understand and explaining them the things. Because when you explain things, even though you don't have quite a real solution, at least patients understand what happens. And it's part of the solution. If we lose this part, we are lost as doctors, because artificial intelligence will do the rest, but there will not be human touch with the patient, and this is very important. And this is something that in general medicine, obviously in our subset of medicine, is even more important because we work as psychologists most of the time as well. But it's something which is very important, and it's a general comment for medicine nowadays, I think. But
if I put you on the spot, and also I'm going to ask you to sort of just give any closing remarks, and then I'll go to the other doctors and do the same. If I put you on the spot and said, in 5 or 10 years, and I'm not saying replace as in doctors don't even look, but is there value in, 1 million data points worth of IVF outcomes, an algorithm saying the best dose for this patient in front of me, based on all the evidence I have in front of me, is to do this, not what the doctor sitting in front of them decides on that day. Do you agree with that?
I think we'll get this point. I think
okay.
So. Because we can see it in other areas, not just medicine. We have seen it in economy. We have seen it in other subsets. Yes.
Okay, perfect. Do you have any last comments about personalized stimulation and medication? No, don't worry if you don't have. We're gonna move on. Professor Drakopoulos, same question relating to are you aware of? Because I'm aware of. I've obviously not used it, but I think one of the drug companies, had an algorithm that was available. Are you aware of, or are you using any kind of machine learning assisted artificial intelligence to help with stimulation, or is it still very much doctor?
Yeah, there have been some studies, a few studies, not a lot. We have much more studies in the lab, as you know, Alan, from your field, with AI for embryo development. Regarding ovarian stimulation, there have been a few studies, especially for the day of triggering, when we should trigger, or maybe for the starting dose. Personally, I don't use this. I mean, this type of algorithms. I think we are not there yet. Maybe I see a point for the day of triggering, especially in very busy units. But otherwise, I think as doctors, we are capable to choose the right doctor, the right dose for our patient. So yeah. So I don't. We're not there yet, but definitely AI will help. I think ovarian stimulation and maybe will help us take better decisions in the future. But for now, I don't think that we are there.
Okay, and I mean, I appreciate you're all being challenged by me today. I appreciate that, and I appreciate your really balanced and measured responses. But I think it's just important. Yeah, everyone talks about AI, and I think a lot of the positives are a little bit overstated. I suppose if I asked it in a very simplistic way, and we'll move on to Dr. Lyubov in a second, it's this concept that, in case the audience didn't know, millions of IVF cycles are done every year around the world. Now, that data is not all captured in one place. That's why we don't have the information. But to get a simple outcome like, did you get a decent number of eggs if you triggered on a certain day, it just sounds quite a simple thing to do, doesn't it? It's not too subtle. So I hope we get those data, because they seem like they're sitting there like fruit ready to be picked. Dr. Lyubov, what's your experience of specifically for stimulation and the patient, not the laboratory, AI, big data, or even your own data, which is big after a few years?
Yes, frankly speaking, my daily practice was told, don't use it. But yes, especially in the triggering, there are still some kind of questions, because we know that our follicles not growing like simultaneously, and some bigger, some lower. Even there are studies with a triggering when we make one earlier and one for 2-3 hours later, or 38 hours, like if we have immature eggs. But everything depends what will be inside of artificial intelligence, what data he will use to inform us. So now it belongs from us, high quality studies, which will be involved there, because he will decide, not we will decide. And frankly speaking, I once had experience, I was making presentation and I was looking for one point. I was asking him about isthmus cell, symptomatic or asymptomatic, and his answer was something different. What do we know? He give me an answer that you have to remove in all cases even asymptomatic isthmus cells. So I've realized that we are too early now to talk. So first, I think we send children to study. So now we have to get all these high quality studies and then push inside, and some very wise people have to make these programs so all of the rest of us can safely use them. I think that it might be our future, but it's too early. And I totally agree with Dr. Iñaki and Professor Drakopoulos that this psychological contact is very important for our people right now. So we have to explain and to tell them why this decision is made and why this decision is wrong. In my practice, I see that people want to talk. They want to know everything. They need to. I try to explain them everything, and it's much easier to work. I totally agree with you.
And I really appreciate that answer. I wasn't really expecting any of you to say, yes, I want to use AI tomorrow. I don't think we should be scared of it. After all, I mean, I don't know about in Ukraine, but in most countries, even supermarkets have tons of data about you, and they make decisions about what to send to you based on the data they hold, right? So it's not, the technology is already here. It's about putting like you say, putting good information in so you can get good information out. But I really like all of you have said the importance of taking time with the patient, listening to the patient, and in my small experience of exposure to patients, because most of my experience has been in a little sealed off lab, is that they just want things explained. They want you to talk it through so they can make an informed decision. And if you do that and it doesn't work out right, yeah, they're upset, but everyone's done the best they can do. So I appreciate all of your answers and your willingness to engage tonight. To the audience, I appreciate that we haven't answered all the questions, but we probably could go on all night if we did. So here's my suggestion to you. If you found one or any of the doctors particularly engaging, and you think I can resonate with them, which I believe is probably one of the most important things, then reach out with your specific questions, because that's kind of what we're here for. So with that, I'll thank all of our panelists, because you've been amazing, and we'll close it off for tonight. And I hope to see you all again soon on the next installment. Thank you very much.
Thank you very much as well, Alan.
Goodbye, everyone.
Thank you. Bye.